Hello, everybody, and welcome. We're just going to give a minute, I think, as people join. I can see the numbers going up. So let's just give it a few more minutes because we had a lot of sign-ups to this event today. So I want as many people as possible. Yes, it's going right up. Yeah, a few more now. So I will just say hello to you all as you join. And also I would like to welcome our guests, Maisie Hill and Sarah Graham. Thank you, ladies, for joining us. Maisie's a coach, a very sought after women's health practitioner, birth doula, and best-selling author. Spent over a decade helping women with period problems, amongst other things, something she knows a lot about, having suffered from debilitating period pain that meant she couldn't walk, let alone work, extreme mood swings and intrusive thoughts. And she spent years trying different things to sort out her cycle. And this led her to write her brilliant book, Period Power, and to create a free guide to help women understand and work with their cycle. Maisie's latest book, Perimenopause Power, is a step-by-step guide. It's a handbook that will help us all understand what's going on with our bodies during the lead up to the menopause and how to deal with troublesome symptoms. I'm so delighted that she has had the time to join us today, share valuable insights into making it a positive and powerful experience. Asking the questions and keeping everything going will be Sarah Graham, the fabulous award-winning freelance health journalist who many of you will have read in things like Refinery 29, The Telegraph, online, and she's also the founder of Hysterical Women blog, which I was reading last night. So I'd like to welcome you and thank you both. Now, I know you're itching to hear Maisie and Sarah, but before we start, I wanted to thank those of you who are joining us today and also for making a donation to Wellbeing of Women. We raise vital funds to improve women's health and invest in research across all of women's gynecological and reproductive health. And we also train the next generation of researchers, doctors, midwives, and scientists to keep us all well. Our work covers the life course of women. So when we start our periods until post-menopause and issues around osteoporosis, frailty, and so on. We also cover fertility issues, miscarriage, stillbirth, birth complications, and also women's cancers. Women make up 51% of the population, and we influence the health behaviours of our families, our friends, and the wider community. So it's really important that we have the best information available to us when it comes to making choices about our health. So much of women's health remains shrouded in secrecy, whether it's period problems, the menopause, or issues like infertility, or in pregnancy, miscarriage, which affects 1 in 4 couples. Please help us break these taboos, raise awareness, and raise funds for our work. And do sign up to our newsletter, attend more of our events. We do these health and wellbeing webinars regularly, and take part in one of our fundraising activities. Your donation and your support will help us find the next breakthrough that will help you and the women and girls in your life. Now, a little bit of housekeeping before we start. We are recording this webinar and it will go up on YouTube afterwards. If you want to ask a question, please do so in the chat box, which you'll find along the bottom. And Maisie and Sarah will try their very best to answer some of the questions at the end. And now I'm going to hand over to Maisie and Sarah. Thank you and have a lovely discussion.
Thank you. Okay, so Maisie, I mean, I was just saying to Janet beforehand, I'm sure this is something we could probably talk about all afternoon. We've got an hour, so we'll do our best. But I know one of the things that we're both really passionate about is kind of dispelling some of the myths that there are around menopause and the perimenopause period. So what are the most common myths and misconceptions that you come across in your work?
Oh, this is a big one. I feel like there are there are a lot of myths when it comes to female reproductive health on the whole, but certainly when we're talking about the menopause transition, there are myths abound. And one of the big inspirations for me for actually writing the book, one of the big motivations, was wanting to dispel those myths, because what I want everyone to know is that the perimenopause period and that menopause transition is a window of opportunity. And this is something that the scientific literature refers to constantly, is that it is a window of opportunity. So it's really important that we are aware of what the evidence base is and of the options that are available to us, so that we can make informed choices about that transitionary period and also the decades that follow. What I would say, I mean, there's like several big ones, and I think we're going to have time to explore these as we talk, but just so that everyone's on the same page in attendance here today, when we're talking about perimenopause, that's different to menopause. So it's a good idea for us all to get on the same page here, because I think one of the biggest myths, to go back to your question, Sarah, is that, oh, well, this is something that will happen to me in my 50s, so I don't need to worry about it until I get to that point in my life. So that is a huge myth that we all want to realize that's not true, because although menopause itself, the average age in the UK for it to take place is 51, menopause only lasts for 1 day. And it simply marks the 12-month anniversary from when you had your last menstrual period. So let's say you stop having periods at 50, 12 months go by, you go through menopause, and then you're postmenopausal. So it's true that it does happen in the 50s, but perimenopause is what happens before your periods actually stop. So when you're still having a menstrual cycle, it might be more frequent than it used to be. It might be less frequent, more spaced apart. There might be new symptoms, but you will be experiencing menopausal symptoms and have a cycle. So I think that for me is one of the biggest myths that we all want to understand, is that this is a process that can start before you're in your 50s. Most commonly starts, I would say, in your 40s, but it can also start in your late 30s or even earlier, because it's a gradual process. So it's important to see it as that. And then the big one is the use of HRT, which I'm sure we're going to be talking about today, because, you know, if you believe all the headlines that we've all seen, then you, like me, until I, started doing this kind of work, thought that HRT was something that was very dangerous and would cause breast cancer and would cause heart attacks. And actually that's not true at all. The evidence base is telling us the complete opposite of that. But there has been a lot of misreporting of some of the trials that have been carried out. So that's also a huge one that I want people to be aware of.
Yeah, no, absolutely. And I know one of the big issues that we see reported quite a lot, or certainly in the last few years, has been around the issue of kind of mental health symptoms perhaps being missed by doctors, or women being prescribed antidepressants instead of HRT. Why do you think that this happens, and how can women, I suppose, identify whether their mood changes are related to perimenopause or not?
Yeah, because it's not just a physical experience. And I think that's the thing, we're often, we're used to the kind of depiction of someone who's menopausal being red in the face and a bit sweaty and, struggling with symptoms along those lines. But actually it can really impact energy, motivation, mood, ability to sleep. And all of these things will kind of tie in together and impact each other. But I think it's really important to consider the mental health side of things, because the kind of the age where we're, as females, most at risk of suicide is 50 to 54. And my personal opinion is that it's no coincidence that that's when estrogen drops off a cliff and we experience significant changes, often, you know, to do with the context of our lives as well. But I think that's the thing, is usually when we're going through perimenopause, there are so many other things going on in our lives, and we're very resilient. You know, and we have been socialized and we have lots of experience of managing hard things in our lives, but often this is a stage of life where there are lots of factors influencing our mental health and well-being. And I think the fact that it could be to do with changing hormone levels will often get missed, because we can explain it away by other things like relationship issues, kids who wake us up in the night, financial struggles, you know, COVID. There's always lots of reasons why someone could be going through mental health challenges, but there are, you know, there is a significant impact on changing hormone levels within that. And, you know, to your point about the antidepressants being prescribed, you know, your blog, you know, a lot of your work, you talk about how women's reproductive issues are often just dismissed as like hysterical issues of hysteria. And I think that is true in perimenopause as well. There's a lot of, or well, if you just relax, or if you just do less. I think that's the thing. There's like still this thing of like, we as women are doing too much, so you should do less and then you won't have these symptoms. And you know, we just get fobbed off, or tried to be fobbed off by this. But I do think on the patient side of things, that there's also that some women, a lot of women are fearful of the use of HRT. So whereas antidepressants maybe feels like more familiar territory, they're maybe more comfortable with the use of antidepressants, especially if they've had mental health challenges earlier in life that have, where they've used antidepressants. But the NICE guidelines, which I recommend everyone looks at when they are thinking about perimenopause or getting involved with any kind of health professional, the NICE guidelines don't recommend the use of antidepressants for perimenopause. So I think that's really important. I like to think of estrogen, which is one of the hormones that changes in perimenopause, as helping us to be more resilient in life. And so when estrogen levels start to shift, I think often women will say to me, I used to be able to cope with these things, and now I'm noticing that I'm not. So I think that's the word that I would encourage people to look at. It's like, how resilient do you feel to what's going on in your life?
Yeah, absolutely. And obviously you talked about the process of perimenopause and this not being something just for women in their 50s to worry about. I'm very conscious, sorry, my dog. I'm very conscious that we're sat here, you know, as women, neither of whom have gone through perimenopause. Why do you feel that it's so important, you know, for younger women, you know, perhaps in their 20s, 30s, 40s, to start having these conversations and be thinking about it now rather than waiting until it happens to us?
Oh, such a good question. So I think one of the things here is that what happens in the menopause transition, it has such a significant impact on the decades that follow. So you want to think about the stuff that's going on in your 40s and 50s is going to impact you for the following 30 years. And when we think about the women's health issues that impact us the most, we're thinking about cardiovascular disease, we're thinking about osteoporosis and having frail bones. And the time when we can be achieving peak bone mineral density, when we can be making our bones the strongest and most resilient, is when we're in our teens and 20s. So it's really important to be bringing this into the way we talk to young people about how they move their body and strength training. And, you know, I think shifting that conversation, because usually, particularly for females, exercise is usually positioned as a way to lose weight or manage weight. And I would really love to see that conversation switched into like us being strong and not being afraid of being bulky and of having muscle strength, because that's just so important for the health of our bones, as well as lots of other health indicators. And also, you know, I have memories as a teenager. I didn't know that's what was going on, and I'm not sure my mum knew that's what was going on, but later on, years later, when we discussed it, she was going through perimenopause, or starting to, when I was a teenager living at home. And I think this
so
is
many hormones flying around.
exactly. And so it can be really helpful for our young people to have an awareness of this, because more than likely there will be someone in their household who is starting that process, or is going to go through that process at some point. But, you know, for those of us in 30s and 40s who are maybe not quite there yet, or maybe starting to tiptoe, I put myself in the tiptoe category. Like, feel like I'm just on the edge and starting to get some stuff happening. I think it's important that we know this, because there are so many strategies and so many options. And, you know, you and I are both very, very familiar through our work that we tend to be socialized to put up with things, and that's something that we have to change, and an area that I'm really passionate about. So I think, you know, the more we're aware of our options, we're more aware of the symptoms, because I often hear from women who are like in the thick of perimenopause but had no idea. They just didn't know that's what was happening, and they were just beating themselves up with negative self-talk, on several types of medication from the GP, because no one, you know, hormones impact everything. So you get such a wide variety of symptoms and signs coming up. And even sometimes medical professionals don't put those dots together and think, oh, maybe this is to do with hormonal stuff. So
yeah, absolutely.
Basically, regardless of your age, it's a conversation that we should be having. Yeah.
Brilliant. No, absolutely. And obviously managing those symptoms that you talked about is something really personal. And we've got kind of a few more specific questions coming up that have been sent in. But what's the kind of best kind of general advice that you would give on how to navigate all the information that's out there, which can be quite overwhelming, I would guess?
Yeah, well, of course, number one is get my book.
Great plug.
It's like I break it down through like these different areas and the different options that are available. And I think the thing is there is a lot out there, and particularly if this is an area that you're not very familiar with, and you're not sure where to go to or who to trust, or maybe you've started to go to speak to your GP but maybe haven't had the kind of conversation you were hoping for, then, you know, there are lots of options available to you. But I think for me, it's really thinking that perimenopause is a process. So, you know, if you're like in my camp where you're starting to tiptoe your way in, then, you know, looking at food and lifestyle things and the use of supplements and, you know, really, I mean, there's the things that I think make a massive difference here is having good boundaries, learning to say no to people instead of saying yes to everything and everyone and running ourselves ragged in the process, supporting sleep, because if sleep is an issue, then, you know, just about every other health issue is going to be impacted by a lack of sleep. And, you know, finding pleasure in our lives, because this is a point in time where we're often fulfilling roles that involve other people. You know, you might be a mum, you might be, well, a teacher, particularly in the pandemic, if you have kids, you know, boss, colleague, friend, daughter, you know, and often we can end up feeling very stretched in this phase of life. So I think it's like really looking at your capacity and what you're able to do, and being honest with yourself and honest with others about what you're up for and what you're not up for. I forgot what your question was. General things.
Yeah, general advice on navigating the information.
I think it's like being flexible in your mindset with what's going to work, because like what's working well for me now, in 2 years' time I might need to change tack. And I was working with a client recently who you know, we were doing lots of work together, and she had started using progesterone under the advice of her gynecologist. And then there were some things coming up in our sessions, and I just kind of went, just out of interest, are you also getting these other symptoms? Like, let's just do a general check-in. And she was like, oh yeah, I'm getting all of those things. And I was like, you know, how do you feel about going back to your gynecologist and talking about bringing in the use of estrogen? Perhaps, you know, like maybe it's time to shift course a little bit. And I think that's the thing, is that our needs are going to change on this process, and what works well for a period of time might stop working so well. You might need to pick a different strategy. You might need to increase your dosage of something. You might need to stop doing certain things. So there's lots of options, and there is no one perfect way to go through this.
Yeah, and that follows on quite nicely to a couple of questions we've had about sort of alternative remedies, lifestyle changes. So Nicola asks, should we be trying alternative remedies, kind of pharmaceutical options before turning to HRT? Or is it okay to start HRT and then also try supplements as well? Or should she only consider both if HRT on its own isn't working? And then Mel also had a similar question. So she has been experiencing very short but very heavy periods, but was reluctant to go for the procedure that her gynecologist had suggested. And she was asking, you know, she's been trying dietary changes, supplements, cycle syncing her workouts. But are there any other suggestions that you have for things that she can try before going down the more kind of medical route?
These are great questions. Oh, there's a lot that we can unpack here. So first of all, what I'd like to say for all of you is to just be thinking, I would get it out of your head, if it's there, that you need to wait until a certain point before you introduce something like HRT, so hormone replacement therapy, because I think it's like, it's seen as like this like bad thing that you should only really use if you really need it. And so what I hear from people a lot is that they're like saving it for when it gets really bad. And you just don't have to do that. You can, you know, if you're wondering if the time's right, you can make an appointment with your GP or a menopause specialist and start having that conversation. And you might come away from that conversation thinking, yeah, I'm not sure it's entirely appropriate for me right now. Or you might be like, yes, absolutely. Or I'm going to wait a few months, but, you know, just start that conversation, because one of the symptoms of perimenopause is, well, there's a few: brain fog, tiredness, cognitive abilities can sometimes decline, and that can make simple or seemingly simple tasks like making an appointment with your GP and going and having these conversations, they can actually become more challenging. So I think it's good to start them earlier than perhaps you might think they are. When it comes to what we would call like alternative therapies, so things like herbs, acupuncture, supplements, there are some contraindications. So you would, this isn't the kind of thing that I would recommend, like you go to your GP and you get HRT and then you just pop into a supplement shop and start just pulling things off the shelf and hoping for the best. If you're thinking about combining strategies, particularly with herbs and supplements, then I would really recommend working with specialists, people who have higher education, maybe degree level, you know, like medical herbalism is like a 4-year degree, acupuncture's a 3 or 4 year degree, nutritional therapy is several years of study. And so you want to work with those specialists who know what they're doing and who can suggest things in a very safe way. So sometimes things can be prescribed together and they will be complementary. Other times they won't be, but certainly, you know, things like acupuncture, you know, you could always be doing, you know, I have a bias, by the way, just so everyone knows, my background is as an acupuncturist. But yeah, there's lots of options there, but I think it's starting to have those conversations with the people who can help you is going to be most useful. what did you remind me what you mentioned about periods? Because that's a very common one, heavy periods.
Yeah, so it was short but heavy periods, and she was trying to manage it through lifestyle changes, so diet, supplements, cycle syncing her workouts. Is there anything else that she could try?
So when it comes to the medical stuff, and just so you all know, when you're asking questions, it's sometimes hard with like specific questions, because I either kind of on a professional and legal level can't make recommendations, or even if I was in that situation, I would need to ask a lot of questions back in order to answer that question properly. But on a general level, what I would say is heavy periods are a feature of perimenopause very commonly. And that happens because one of the hormones that starts to decline in our late 30s and certainly in our 40s is progesterone. And that's the hormone that is produced as a result of ovulation. And it kind of runs the show in the second half of the menstrual cycle. So one of the things that progesterone does is it has a lightening effect on periods. So as you get more into perimenopause, you start producing less progesterone generally, but you also don't ovulate as often. So you don't have the event happening that's going to produce that hormone. So what can happen is that you start to have heavier periods, longer periods, episodes of flooding, blood clots, things along those lines. So there are lots of strategies, and there's a section on heavy periods in the book, but there are supplements and things that can help. But just as terms of frontline treatment, taking an NSAID, a non-steroidal anti-inflammatory like ibuprofen, can dramatically reduce blood loss. So, you know, that's just a great one, you know, if it's safe for you to take, you know, maybe have a conversation with a pharmacist or your GP, but that can be used to reduce blood flow. There are also certain supplements like curcumin, which is the active ingredient in turmeric, that work in the same way. So those can be useful. But you can also be prescribed through your GP body identical progesterone, which is a form of HRT, and it's the same progesterone that you make yourself, but it's derived from yams, and that can have a significant improvement on heavy periods. And you can either take it in the second half of your cycle, or if you're experiencing very heavy bleeding and maybe your periods are more erratic and happening more frequently, then you can take it on a different schedule. So that's, you know, just for all of you, the context of why that might be happening, and just some kind of general recommendations that could help.
Brilliant, thank you. While we're on the subject of HRT, then there was a question from Lisa, who has been on HRT for 5 months, but she says she is still experiencing low energy and mood. She's asked her doctor if there's any kind of test to see what she's lacking, and they've said not really. So she wants to know, how can you be sure that you're getting the right dose of HRT? Are there any kind of tests to check, or is it just a kind of trial and error?
It's trial and error, really, you know, and that sounds like it's unhelpful. I think it's actually a good thing, and here's why. For most of our reproductive years, for most of our life, our experiences aren't listened to. That's a sweeping generalization, but certainly the conversations I have with women, they often feel like they're dismissed, not heard, and not getting the care that they would like to have. By the way, I'm not anti-GPs or the NHS. They do a wonderful job. I hear lots of positive things as well, but a lot of women have had this experience. So the thing about perimenopause is it's diagnosed according to your symptoms and according to your experience, which I think is a good thing. Sometimes there are, you know, your GP in particular cases might recommend blood tests and other lab testing, but on the whole, we just look at what's going on with the cycle, the new symptoms, date changes, things like that. That's how perimenopause is diagnosed. So it's the same when you are using things like HRT, is looking at, or any other kind of strategy. Are these symptoms improving? Is your health and well-being improving? And I think that's what's important to go with. And if you are using a particular strategy and you're not getting much of an improvement, then that's a good indication to go back to your GP with that information and discuss what might be next, because it might be that a different formulation or a different method of delivery, a different dosage, using things in combination with each other, all of those things might be appropriate. So the best thing is to go and speak to your GP.
Yeah, brilliant. And one of the questions that I'm kind of noticing a lot in the chat box actually is, you know, I've got a few of these symptoms, how do I know if it's perimenopause or not? Presumably the answer to that is go and have this conversation and see what your GP thinks.
Yes, I agree with that. But I will also give a caveat to it of, as I said, a lot of GPs are wonderful and very passionate and educated about this, but not all of them are. And I have had some clients and some women say to me that they've gone along to their GP, like knowing that they are perimenopausal, but their GP, you know, they literally tick all the boxes on a checklist, but their GP said something to them like, well, you still have periods, so you can't be menopausal. So I would say bear that in mind. But again, you know, just familiarizing yourself with some of the common signs and symptoms. I mean, the thing is, hormones impact everything.
Yeah.
So it's a wide variety, which is why sometimes it can be can be missed.
And I mean, obviously GP education is, like you say, it can be a big barrier. How can women kind of advocate for themselves if their GP is saying, oh no, it's not this, or you're too young, or whatever?
Yeah, I think the best thing really is to print off those NICE guidelines that we talked about and familiarize yourself with those. They are in quite plain language, so you know they should be accessible in order for you to make sense of them, and to just go in with that and say, look, this is what's going on, and this is why cycle tracking and like noting your symptoms and your experience is really helpful, because this is like, it's not just a nice thing to do, you're actually collecting data about your health, and then you can use that data to communicate with the people who are going to find it useful. So, you know, taking your data, taking the NICE guidelines, have a bit of an idea of, you know, maybe understanding of why something might be going on, and you know my book's going to be really helpful in figuring that out. And you know, often when my clients do that, they often have a very different experience than if they just kind of show up and be like, well, I've got this and I've got that. Of course, if you have an experience that you're not happy about, then you can give feedback. And feedback can be really important, and I encourage my clients to do that through PALS, the Patient Advice and Liaison Service, I think it is. Yeah, every trust has one, and to go and give them that feedback, because once you give them feedback, they then need to deliver that feedback to the healthcare professionals that were involved in your care. And that can be done anonymously. I've had some of my clients have face-to-face meetings mediated with people, and so many positive things have come out of those, you know, where like some trusts have completely changed their ways, their strategies of doing things based on that feedback. So I think it's really important for us to be aware that our experiences count for something, and they can be used in very positive ways. I mean, there's all sorts of other little things we could get into here. You know, it's things like if you're being examined in some way, don't have a conversation when you're lying down on your back and you're, you know, like having a pelvic examination of some kind, because you're already in a vulnerable position. And, you know, I mean, I I hate this, but I get why it happens. Like, some of my clients have taken in their husbands with them to their appointments and had a completely different experience. And I think it's awful that, you know, they've had to go to that length. But, you know, if you live in a place where there's one GP practice and you've got one of two GPs who you can see, then, you know, and you're struggling, you've got to do what you can to make a difference.
Yeah, no, I mean, that's something that I hear a huge amount in my work as well. It's depressing, but the reality often. Okay, so a couple of questions that we've had on kind of physical symptoms. Samantha said, despite eating healthily and being very active, why is she still struggling with an increase in size on her thighs, hips and waist? And is there anything she can do about it?
Well, this is a complex topic. There's a lot of nuances to this conversation. But again, it's a very common feature, and I would say, being in some Facebook communities that are specifically to do with menopause, this is probably the most common topic, is on strategies to maintain weight or to lose weight. Sometimes it can be on gaining weight, because some people will lose weight during perimenopause. I say all this under the umbrella of we live in a society that favors thinness, and, you know, there is a lot of shaming that can go on around body weight, body composition, appearance, all of those things. You know, the way that BMI, body mass index, is used is completely inappropriate, and, you know, its history is also very inappropriate. So the just to put that out there, but our bodies do change in perimenopause, and that brings challenges when our worth as women is often based on how we look and the things that we do for other people as well, I would say.
Yeah, absolutely.
So I think some of it is to do with re-educating ourselves and re-educating the people around us that bodies look different and bodies change, and that's just a normal part of the aging process, and it doesn't mean that anything has gone wrong. Changes to metabolism happen as a result of the hormonal shifts that are going on, and there can be a redistribution of weight. And, you know, so that might be, this person's question is why it was appearing, or why it's appearing at certain parts of the body that maybe they're not used to. And, you know, and the fact is that will happen, you know, regardless of what's going on with your diet, regardless of what's going on with exercise. But what I see happening in my clients is this increased intensity around the desire to lose weight, which I totally understand, but often that in itself can drive weight gain. So, you know, they will like become more restrictive with their diet and perhaps cut out whole food groups like fat. And actually you need fat to make hormones, the hormones that are going to support your metabolism and everything else that's going on in your body. The same, they'll like suddenly cut out or dramatically reduced carbohydrates from the diet, and carbohydrates are really important for soothing the nervous system. So it's like, yes, there might be some temporary weight loss, but that can come with more stress, inability to sleep, disrupted sleep, not particularly pleasant, or an increase in kind of mood changes related to the cycle. I told you this was a complex topic. There's a lot.
Yeah, I'm sure.
Yeah. But I talk about that because I think it's, and also with, you know, exercising harder and for longer in this drive to lower your weight, and actually what can end up happening is you end up gaining more weight because of the stress that you put yourself under, the inflammation that's caused a result, the lack of sleep that happens, and all of those will impact on weight, but also on other areas of health. So this might not be the answer that you're looking for, but I feel like so much of our work in perimenopause, and one of the benefits to perimenopause is that we become more comfortable with ourselves, who our experience of being in our bodies, how we present to the world, showing up as ourselves, being ourselves. I feel like, let's do that work first.
Yeah.
Let's do the work on loving ourselves as we are, and then from that place make decisions about what we want.
Yeah, I think that's brilliant advice. Okay, another question. So Liz asked, is it normal to be experiencing lack of strength and dexterity in her hands? So she gave examples of things like opening jars, using screwdrivers. It'd be good to understand a bit about these kind of random symptoms that you might not necessarily associate with menopause.
I know, I love this question, because it was really, I came to writing this book based on my clinical experience and, my work as a practitioner and the stories that my clients have told me over the years. So I was well aware, before I started researching and writing it, of the impact hormones have. But still, when I was reading all the medical literature and researching it, I still was continually going, bloody hell, they do everything. We have hormone receptors all over our bodies, in our brains. So when hormone levels start to shift, we feel it like across the board. And that's why you can have, changes to cognition, like your ability to think, your ability to recall information, changes to body composition, changes to your cycle, your mood, like we just, skin changes, heart, blood vessel changes, everything shifts. And it's the same for like muscular strength as well. And actually declining estrogen levels do impact your ability to grip and pinch, like that pincer movement and gripping does start to shift. So it's estrogen levels starting to decline, is what's going on there.
Interesting. Okay. So there's a question here from Elaine about surgical menopause. So for anyone who is going through menopause as a result of having ovaries removed, fallopian tubes, anything like that, would this be different from those going through perimenopause naturally? And she also asks if you've got any advice for people who either can't or don't want to take HRT because of a history of breast cancer or a family history of breast cancer.
Okay, right, let's separate this off into two things. Right. So first of all, remind me of the first part of that question.
Surgical menopause, is it different from a natural perimenopause?
Yes. So let's say you have your ovaries removed, then you would go through menopause would be instigated because of that. So that's a sudden shift. We're not talking about like with what we would call natural menopause. Your hormones gradually shifting, and then at some point your periods stop. Like that takes place over the course of years.
Yeah.
With surgical menopause, like you have your ovaries removed and you're in menopause immediately. And depending on the reason for the surgery, there might be other surgical techniques that are used that also impact the recovery. So I talk about hysterectomy, or I call it uterectomy in the book. I just found that fascinating that vets call the removal of the uterus uterectomy in animals, but in humans we still call it hysterectomy, which is based on us being hysterical because we have wounds. So I do unpack that in the book, but I would say if I was going to give a kind of general suggestion, would be that if you are going to be having a type of surgery along those lines, would be to talk to your surgeon or a menopause specialist about the use of HRT, even if it's like a short-term strategy to help you recover from the surgery and to help you adjust, like that's an option. So it is different because it's sudden. And you mentioned breast cancer as well. So, I mean, to go back to the data that we have, this idea that we that HRT increases your risk of breast cancer is untrue. That's flawed data. Like the design from that study, the Women's Health Initiative, wasn't rigorous, and the way that the data was analysed was also flawed. But that's still where we get this belief from, this perception that HRT is dangerous. So when we're talking about breast cancer, and this can mean in someone's family history, or it can mean their experience of, their health of having breast cancer. Of course, there are different types of breast cancer that we're talking about. So there might be some variation there. Say if you have a hormone receptor positive cancer, then maybe HRT might not be the first place that you start with. But that being said, some people who have had breast cancer may make an informed decision to use HRT in conversation with their oncologist and a menopause specialist who can prescribe things, because you just might decide that you'd rather live your life with feeling better in certain aspects of your health, but it's going to be down to the individual really, and this is where speaking with specialists is of the utmost importance. But on a general level, this idea that HRT causes cancer, we just need to do away with that.
Yeah, absolutely. Okay, one of the questions that I've noticed coming through quite a lot in the chat is to do with postmenopause. So for anyone who is postmenopause, they've had their anniversary of their period stopping. First question, is the book still relevant to them? And also, is it too late for them to kind of do something to manage their symptoms or whatever? Is it too late once you're past the menopause?
So yes and no. That's a quick answer. Yes, the book will still be appropriate, and no, it's not too late. Those is still, we started off this conversation talking about how it's a window of opportunity, and I think that's the thing. Is often we're talking about, even today and in the chat, we're talking about the management of symptoms throughout perimenopause, but the decisions we make there, this is why I kind of caution people who are like, well, my symptoms, I've just got a little bit of this and a little bit of that, and I can kind of get through. It's like, well, that's great, but let's start to think about the decades that are going to follow and how you can support your health there. And if you are postmenopausal, then there are still some decisions to be had and things that you can do that are going to really influence things, and that might be through the use of HRT, it might be through strength training. And one of my pet peeves is whenever you see like an older woman exercising and doing strength training, they've got like these piddly little dumbbells. And I think, well, that's great, we all need to start somewhere, and I certainly started off there. But we are strong, we have a lot of strength, and we can do more, and so you can start doing that. I've read examples of women in their 70s and 80s starting to do like big full-on weightlifting. So it's all available to us really. And even if your periods have stopped, like there's particularly, I'd say, like a period of a few years around that time when you can still really influence bone mineral density, and even thinking about the risk of cardiovascular disease as well, cognitive function. We're thinking about things like Alzheimer's, neuro diseases like Parkinson's. We can still hugely influence them. So yes, it's all still appropriate, and you haven't missed out. You haven't missed the window of opportunity. It all still applies.
I'm really conscious of time, but there are two more questions that I want to just try and fit in before we finish. So the first one is, we haven't talked yet about sex, and I've noticed there've been a few questions in the chat about libido, and something that I hear about a lot is women going to their doctors with kind of menopausal sex issues, and this kind of almost it kind of being a bit brushed off as like, oh, women over 50 don't need to worry about that, like you shouldn't be having sex at that age. What can women actually do to have a good sex life in the menopause and beyond?
Yeah, this is a huge frustration of mine, because I think, I would hope it's improving, but I think going to your GP to have a conversation about well, what we call genitourinary genitourinary symptoms of menopause, it can take a lot to actually instigate that conversation and to say, look, I'm got a really dry vagina, or I'm finding sex uncomfortable, or not even that, I'm finding sitting uncomfortable. So it can take a lot for someone to get to that point where they actually feel that they can raise that. And very sadly, they're often, you know, eye contact stops, no questions are asked. It's like, oh, okay, that's an issue, let me just suggest these things to you. Or I do think generally, you know, they don't want women over 50 having sex. And I think like this is one of the reasons, I suspect, why it's hard for women in this country at least to be prescribed testosterone as part of their HRT combination, because if you live in Australia you can just get it, whereas here you can kind of have to fight a bit to get there. So yes, you could like definitely think about the use of HRT, either a local application or, you know, to the vulva, to the vagina, or you know, you can take it systemically, which, you know, just influences all of the body. You can also combine those things. I'm a huge fan of lubricant at any age, and it's been interesting.
It's underrated.
I know, it's fantastic. Some of my clients, you know, who have been in their 50s have been hesitant because they've kind of seen the use of lubricant as they've made that mean a lot about them. And when I've said, well, I used it in my 20s and I used it in my 30s and now in my 40s, and then I think we kind of get away from this image of a withery vagina, basically. But it is really important, you know, for anyone having these symptoms to speak to your GP, because they can refer you for to see specialists, and it also impacts the way that you access other types of medical care. So if you're going for your cervical screening, which is really important, you might be put off going for that appointment if you know that penetration is painful for you. So yes, we want to like think about what's going on in our sex lives and experiencing pleasure and feeling fulfilled in our sex lives, but it also has an impact on other health behaviors like cervical screening. So don't take no for an answer. Get that down the door.
Great advice. No, thank you, Maisie. And just finally then, I wanted to finish on this question. So it was from Marie, who says that her understanding of her cycle was really transformed by reading Period Power, which I think is true, you know, of a lot of women, myself included. But in perimenopause, her cycle is now shorter. And she wants to know, will she still be ovulating 14 days before her period? And how can she recalibrate her understanding of the seasons of the cycle that you talk about in Period Power, now that those seasons are changing?
Oh, so here's the thing. I have to give some context here. It's never straightforward. When we talk about a menstrual cycle, we often talk about one that's 28 days, and that's like seen as normal, but actually only around 12% of us have a cycle that's 28 days. But let's work with it, just because I think it's useful. So if you have a cycle that's 28 days, you might conclude that you ovulate on day 14, and then the second half of your cycle is 14 days in length, because the second half of the cycle, the luteal phase, is seen as more fixed in length, and the first half varies. So, you know, if you have a late period, for example, you actually ovulated late. But you can have a second half of the cycle that's 9 days long. So even if you still had a 28-day cycle, you might not be ovulating until what is it, day 20, day 21?
Yeah.
Maths is not my strong suit. So even if you have a quote unquote normal length cycle, you might not be ovulating on day 14. And this is particularly true in perimenopause because, as I mentioned, progesterone starts to decline, and we kind of see that second half of the cycle isn't as supported by your hormones in the way that it would have been pre-perimenopause. So you can start to have a shorter luteal phase, or you might have premenstrual spotting for several days before your period actually kind of gets going and is in full flow. So no, don't assume that you're ovulating on day 14. And this is important because if you are having something like your progesterone levels checked, then progesterone peaks around 5 to 7 days after ovulation. So, you know, you want to make sure that you're getting it tested at the right point in your cycle. But basically, when it comes to perimenopause, it's all up for grabs. Like, it could be that the first half of your cycle is long or short, the second half is regular or short. You might not be ovulating at all, but still experience enough hormonal activity to instigate a bleeding episode. By the way, if you are postmenopausal and you have a bleeding episode, that is a red flag. You should always go to your GP and get that checked. So it's basically, it's a huge time of variation. Yeah.
Cool. Okay, fantastic. Great. Over to you, Janet, to wrap up. Thank you.
That was fascinating. Can I just say a huge thank you, Maisie, for being so open, for being so honest about this extremely important subject, which pretty much every woman is going to go through.
Yeah, that's the thing. None of us are going to get away from it.
It's a natural stage, and we want to talk about it more, and you are helping do that. So thank you very much. We want to make sure that women have as much information as possible and can advocate for their own health, because then it will be better for them, and that's what we all want. Yeah. Sarah, I think you've done a marvelous job. I really do. Thank you for managing this and for incorporating so many of the brilliant messages and questions. And to our audience, can I just say you have been fabulous. Thank you for joining us today. It really has been interesting reading all your messages and your questions. There really is a great need to have better information, and we all need to be educated about our own health. That way we can make it better for ourselves, and we can make it better for our children, for our friends, and everybody else. So I'm just gonna say a huge thank you again, and we look forward to welcoming Maisie and Sarah back at some stage, and also all of you. It's been a really good hour. Thank you very much, and goodbye.
Thank you.
Thank you.
Thank you.
Yes.